Un peu, Laura m'a dit qu'elle a très froid.
Hein?
Laura elle vient de me dire qu'il fait froid un peu dans ça.
Oui,
moi je suis bien habillé, mais c'est...
Elle a de la progestérone, c'est pas pareil.
Okay, so let's move now for the urinary tract endo. So we will do urinary tract, then we will get a Zoom discussion with Elder about the role of ICG you have seen already. And then that will drive us to the lunch and the lab this afternoon. So Nasir, thank you for the urine.
Thank you. Good morning. I would like to start to tell you that I am not urologist, that after this presentation every time I got asked about that, and that we learned in the school of Professor Vattiez that when you deal with the frozen pelvis or complicated situation of the pelvis, you have to develop collateral competences to know how to deal with the organs that you encounter when you operate this kind of surgery, whether you want to do yourself or with a colleague, it's good to know how to perform these techniques. So I have nothing to disclose, and this to start with the anatomy of the ureter, that it's an organ of 30 centimeter or to 35 centimeter running from the kidney to the pelvis to the bladder, and during his pathway he is vascularized by some tiny vessels, like called T-shaped vessels, at the level of the lumbar area, coming from medial to lateral, and in the pelvis from lateral to medial. And all the vascularization comes in a network in the adventitia. So from oncology, you can see at the end of the surgery, usually this ureter is dissected, all the pathway without harming the function, being detached completely, and it's still keeping the function. So message, keep the adventitia. For the endometriosis, ureteral endometriosis is very rare, and it's about 15% of urinary endometriosis. Itself, it's 0.3 to 0.6% of all endometriosis cases, and 30% of the patients have reduced kidney function at the time of the diagnosis. This is what is very important. So it can be from outside, like a compression from outside, and it's up to 90% of the cases involving the adventitia and the muscularis, and less frequently it's intrinsic, so involving the mucosa, around 10% of the cases. So you can see here a photo of a case of Professor Vattiez, a young lady with a bilateral intrinsic endometriosis of the ureter, which is very rare. So localization, mostly on the left side, and why the left ureter is more involved than the right ureter, it's probably due to the sigmoid loop that bother the circulation of the peritoneal fluid, and it's stuck at the level of the left iliac fossa. Mostly, the most frequent site is the ureterosacral ligament, and the second most frequent localization is at the level of the ovarian fossa. What are the symptoms? most frequently the symptoms are not specific, and it is dysmenorrhea, like the classical symptoms of the endometriosis, which is dysmenorrhea, dyspareunia, or chronic pelvic pain, and less frequently it's indicative of the urethral or urinary endometriosis with renal colic in 5%, lombalgia 30% of cases, dysuria, and sometimes hematuria. 50% of patients have no symptoms or urinary symptoms at the diagnosis, and this lead to the silent renal loss. So we can have loss of the function of the kidney without any symptoms, and this is very important to consider. What is the workup before the surgery? Imaging, and we have seen yesterday that ultrasonography plays a big role in assessing the patients preoperatively. We can see the pelvis and consider always to put the probe at the level of the kidneys to see if you have a dilatation. It's not very difficult to see. MRI is also very informative, and we can also do some EuroCT. If you see a dilatation of the kidney, consider a scintigraphy of to get an idea of the function so that you can inform your patient before the surgery that your renal function is already compromised so that you can avoid problems postoperatively. When to put a JJ stent? This was also published by the group of Strasbourg. We consider to put a JJ stent before the operation when you have dilatation of the kidney. When you have a history of ureteral lesion on a previous surgery, so you have done a laparoscopy before and you have seen that the ureter is compromised, and if you have not done a stenting before the surgery, you can always do a stenting during the surgery when you see a ureteral dilatation that was not recognized preoperatively, when you have an accidental injury, or when you decide to operate on the ureter, so if you want to resect, and if you have accidental thermal damage, or you check a stenosis on the ureter at the end of the surgery, so you can always stent during the surgery to prevent ureteral obstruction after aggressive surgery. How to deal with ureteral endometriosis? You always start your surgery the same way. So the general strategy is almost the same. You start thinking about the exposure. So you have seen in the two surgery, the surgeon started by detaching the sigmoid from the left side and suspending the adnexa so that you can deal with the ureterosacral ligament correctly, or the nodule on the ureter correctly. So consider this C-lift suspension of the adnexa. It keeps your assistant always available to help you. Use your anatomy. In these cases, we always repeat that the anatomy, it's true that it's distorted, but your landmarks are always the same. Preserve the blood supply of the ureter, and when you deal with the ureter, you need to handle it with care. Avoid using energy close to the ureter. Push it away when you want to apply energy. Preserve the adventitia. Do not devascularize, and consider always the blunt dissection in order to avoid injury of the ureter. Keep your ureter always under vision, and then you apply a specific strategy according to the localization you have. If you have extrinsic compression, mostly ureterolysis can do the job. And sometimes, if it's not enough, if you keep on having disease compressing the ureter, you sometimes perform resection, anastomosis, reimplantation. I will go through this. Anyway, so again, always keep your ureter under vision because sometimes you have injury outside the screen. How? You always keep your ureter under vision. Sometimes your injury come from the assistant outside the screen. How to deal with the ureter itself after you exposed, after you freed your Douglas, and then you see the disease on the ureter and you go to decide what to do. You always start with ureterolysis. And if you have injury or stenosis on the wall of the ureter, you can see devascularization, you can see some injury of the wall, you can consider stenting, you can consider odontoplasty. It can heal after ureterolysis without doing more. Usually we keep the stent between 2 to 3 months and Foley catheter for 2 weeks in order to decrease the pressure and the reflux of the urine in the ureter. Here it's a video that you have seen yesterday. As I was repeating that most frequent localization is uterosacral ligament on the left side. So uterolysis can put away the ureter and you can have the job done just by ureterolysis. Here it's a little bit more tricky. I just show this video to tell you how to do ureterolysis, not to use energy, blunt dissection, stretching, slow stretching in order to decrease the bleeder. And this message you have heard already this morning. Sometimes you have to cut in order to keep on freeing. As you see, scissor, no energy at this level. And when you have some freedom of the ureter, you can proceed by applying energy. So you use these divergent forces, you detach very slowly, you cut with the scissor. As you see, if you have some bleeder, you can use the suction device by suctioning and pushing, and slowly you can free your ureter. And then when you have it a little bit away, you can apply energy on the disease and to keep on freeing. As you see, once you have ureter a little bit far away, you can proceed by applying the energy you want, and you keep on going this way. Sometimes it's a little bit more difficult and tricky. As you see here, we have had a big dilated ureter with compromised renal function. The disease was compressing intrinsic way, so the ureterolysis is not enough. Same principles, you apply no energy close to the ureter, and if it is not going, you push away the ureter, you apply energy. Then, after freeing completely, I was saying that ureterolysis is usually enough, but you can guess in this kind of situation, the problem will not be solved only by freeing the ureter, and a reimplantation was needed in this case. You can see the distal segment after the compression was very tiny, and this stenotic part was completely resected, and ureter was reimplanted after resecting all this left parametrium that was involving completely the ureter. So sometimes you perform the ureterolysis and you have a look and you make a decision. You see a little stenosis on the distal part of the right ureter after complete ureterolysis. You can have in mind, when you have multiple lumen opened, the risk of complication increase. So since the vagina is opened, the ureter, if you want to resect and to resuture, you can have two close suturing areas close to each other. Either you decide to resect and to reanastomose, and you put a separation between the two lines, and also you can consider this possibility also an alternative to have a balloon dilatation by ureteroscopy and a JJ stand after that. It can solve the situation without resecting and cutting. Ureterolysis is not always safe. You can have a devascularization after cutting the disease, even by not using energy, just by cutting the disease, you can have resection of some parts of the adventitia. And at the end, inspection is very important. You can see on 1 centimeter, you have a part of the adventitia injured. If the injury is less than 1 centimeter, you can be preservative and by stenting and putting one stitch, closing this or invaginating this part of adventitia harmed, and this can solve also the situation and can avoid fistula and stenosis afterward. So we leave always a stand for mostly 2 months, and we perform a Euro CT 1 month after in order to see the results. Consider always this anatomy and that this Yabuki space, if you develop it between the vagina and the ureter, it can give you some freedom and it can give you a vision on the distal ureter when you have disease very low, close to the bladder. Having the ureter under vision on this level is also important, and avoid thermal injury during dissection and resection. When it involves the wall itself, you need to resect the disease. So ureterolysis always, but then you have to decide if you have seen that the ureter is not completely free and the diameter is not okay, resection with end-to-end anastomosis or resection and reimplantation. Consider always anastomosis. If you have more than 1 centimeter of distal segment before getting into the bladder, you can succeed to put stitches. It's more conservative than reimplantation. If you have less than 1 centimeter of distal segment, or if you see that the distal segment is not very well vascularized, consider reimplantation. You avoid reoperating the patients. If you have intramural compromise of the ureter, you need to cut and to reimplant. How to do anastomosis? I have seen so many of you yesterday cutting and reanastomosis the ureter. It's mostly the same principle. You suture and 4 cardinal ligament. No need to have watertight stitches, just to have good approximation of the two parts of the ureter, and to have extra mucosal stitching. You don't need to have extra verted mucosa. This leads to fistula. Tension-free anastomosis is very important, and it's a rule to do an anastomosis in order to avoid fistula and stenosis. Here, for example, we have had the stent before the surgery. The disease was resected, and as you see, stitches to put together the two parts without tension, using always a monofilament, resorbable stitch. Monofilament decreases the inflammation and the development of granuloma and stenosis. Resorbable stitches is also a rule, with very tiny stitches, 40 or 50 stitches. And then, as I said, no need for watertight stitches, just to have a good approximation of the two extremities. And you leave the stent for 3 months, again Foley catheter for 2 months. If it happens that you have the section of the ureter without stent, you can always put the stent. And here I show you this video just to tell you also it's an option to put the stent through your trocar by laparoscopy, Spatulation is important. Why? In order to widen the extremities and to have larger area of stenosis. When you do spatulation, have 1 centimeter spatulation of each extremity, and then you start with the first stitch putting together the two extremities, and then from the trocar you push the foley in the proximal part first, and then you remove the guide, and then the assistant help you keeping the loop, and you push the stent in the distal part. You can guess that the stent is well positioned by the release of the angulation and of the curve of the stent, and then you proceed with extramucosal stitches. Leave a little bit longer the extremity of the stitch in order to expose the posterior part, and then you proceed with the suturing. As you say here, I don't need to tell you the message to practice your suturing, because sometimes you need to suture with 2 hands according to the axis of suturing. And then we use this omentoplasty. When you do omentoplasty, you cannot bring directly the omentum down to the stitches. You perform a flap, whether right or left, keeping the gastroepiploic vascularization, and in order not to have a big flap over the bowels, it's not physiological. Like this, you can separate the line of the stitches, and it help healing. So what are the rules in order to do an anastomosis? Here, for example, we knew about the disease before. The patient was having a stent before. It's a video coming from IRCAD, from professor, and resection of the disease with a T-inverted resection, stitches with 4-0 or 5-0 monofilament, tension-free are the messages for anastomosis. Again, the omentoplasty, I have spoken about it. And what about reimplantation? This is one technique of reimplantation that we learned mainly here, and it's called the psoas hitch. What does it mean? It means that after resecting the disease, and you need to reimplant the ureter in the bladder, you move the bladder to the level of the psoas because you don't have enough length. First, it helps you put away the anastomosis and the reimplantation from the pelvis, which is the most frequent area of recurrence. It decreases the tension, and it prevents the risk of post-operative recurrence and stenosis and hydronephrosis. How to do so? The surgical steps are bladder mobilization. How we do this? We open the space, which is an avascular space in front of the bladder. I will show you how to do so. We mobilize the ureter, we do the resection of the disease, and then 1 stitch or 2 stitches to fix the bladder on the psoas, and then we do the reimplantation with 4 stitches or 3 stitches in the bladder. This is a case of uretero-vesico-vaginal fistula after a hysterectomy and resection of the parametrium for endometriosis, and you will see how to deal with this situation. So first, you separate the 2 fistulas, and you can see here the lumen of the vagina, and here the lumen of the bladder. So here it was the vesico-vaginal fistula, and very quickly you see the catheter in the left ureter. So we understood that the distal part of the ureter is necrotic. So we perform a resection of all the necrotic tissue. We need to vitalize the border and the edges of each organ. We separate the bladder from the vagina. We do suturing of the bladder itself. We remove the catheter from the bladder. And we do suturing of the vagina again alone. Here we have 2 lumen with 2 lines of suturing very close to each other. So in order to avoid recurrence of fistula, we put an omentum in between. So we continue by suturing the vagina with a running suture alone, suturing of the bladder alone, and then we perform a resection of the distal necrosis of the bladder with maybe some residual disease here. So we keep on going in order to see normal and vascularized tissue. The distal part or extremity of the ureter was resected, and then we mobilized the bladder. How to do so? You watch the oracus, and on the dome of the oracus, you cut and you go in this so-called radius space, which is the space between the pubic bone and the bladder. It gives you freedom of the bladder, and it helps you mobilize the bladder outside the pelvis. Here we reach the Cooper ligament, and then 2 stitches or 1 stitch on the psoas muscle. Avoid here the genitofemoral nerve when you stitch the bladder on the muscle. And we continue freeing the proximal part of the ureter in order to have tension-free reimplantation. When we do reimplantation in the bladder, we blow a little bit the bladder, we fill the bladder with some liquid, and then we perform a 2 centimeter incision in the detrusor muscle. Why? So we can have an anti-reflux system by closing the detrusor above the extremity of the ureter going inside the bladder. So after preparing the distal part of the ureter with a little spatulation in order to open the extremity and to have a wide reimplantation, we do with monopolar an opening in the detrusor muscle, and then we open the mucosa, and with 1 stitch, in out the bladder, in out the ureter at the level of the angle of the spatulation. This is the first stitch, and then you put the ureter, in fact, the JJ stent in the bladder. So after performing this first stitch, you push the catheter inside the bladder, and then you finish with 2 or 3 stitches of the extremity of the ureter inside the bladder. Here again, exercises of suturing. Just knowing how to perform the technique, you can proceed and perform these sutures. After putting this extremity of the ureter inside the bladder, you can close the detrusor muscle with 2 stitches above this extremity so that you have a little anti-reflux system, and the surgery was done. So post-operative follow-up, as you see here, we have put the omentum between the bladder and the vagina, and since this suture is outside the field, you don't have the risk of confrontation between the suturing line. So post-operative follow-up, CRP every 48 hours, it has to decrease. You do first day 1 CRP, it might go higher up to the 3rd day, and then it has to decrease. You give to eat very early, no need to put the patients on fasting, and low molecular weight heparin, no need for systematic antibiotics, and patients should get better every 12 hours. We leave the stent for 3 months and the Foley catheter for 2 weeks. And if you have no news, it means you have good news. Complications, mainly when you deal with the ureter, whether ureterolysis, whether anastomosis, you risk to burn it, and you risk when you put stitches to have fistulas. So the risks are fistulas and stenosis. Very easy to diagnose. The early diagnosis is very important. The delay leads to more complication. So fistula can lead to urinoma, it's very painful, And when you have sutures, suture dehiscence leads also to urinoma. The stenosis lead to lombalgia, and this has to raise the question marks. So delayed diagnosis here, for example, we have dehiscence of the sutures, and with urinoma, immediately decision of reoperation. It's feasible when you operate very early to redo the stitches. So you remove the necrotic tissue, you resect again the extremities, you free the ureter to get more mobility and to perform sutures with no tension. So as you see, it's feasible to resuture and a resection of necrotic tissue at the proximal part and on the distal part, and adding again stitches. Watch out not to cut the catheter. You resect completely until you have pink and vascularized tissue, and then we do like it is a classical anastomosis, doing 4 cardinal stitches. Extramucosal stitches, tension-free stitches are the rules to perform anastomosis. When you finish, in order to avoid delayed diagnosis, careful inspection of the dissected area. If you see a wall discoloration, if you see that the capillaries are not refilled, if you see that the ureter is not moving, so this vermiculation of the ureter is also informative for a good function. But if you have any doubt, always consider cystoscopy, because when you see the jet, it is almost pathognomonic of good function of the ureter. So if you have any doubt, do not hesitate to add 1 stitch. If there is no stent, to put a stent, and to do the cystoscopy to check the urinary jet. So in conclusion, always look for your ureter in deep endometriosis. When you have nodule in the pelvis, check your ureters. They are almost constantly retracted medially. When involved, you perform first ureterolysis, and if you see that it's still stenotic and involved, you decide whether a resection or reimplantation. Conservative treatment is always better and gives better results. Thank you for your attention.
Thank you, Mathieu. Any question on the ureters? What is the percentage of cases that are solved only by ureterolysis, in your experience?
More than 95%.
More than?
95%.
95. This is the number that is in the literature, 95%. So it means that we don't do too many reanastomosis and reimplantation.
Very little. To be honest, these 2 cases I showed you were in 5 years of practice.
And you said that try always to do anastomosis, and the urologist tell the opposite.
The urologist always say the opposite. And this case of putting the catheter from the trocar was after a big discussion of urology saying do a laparotomy. It's not an adventure, it's not a challenge. After finishing the surgery, we were like, why just to open to put a catheter? So it was solved by laparoscopy. So just to tell you that we do not have the same concepts.
Wait, because the urologists don't say because of the catheter, they say because of the risk of stenosis.
Yes.
This is my point. My point is
that you suture better, that you, and as
no,
you...
but it's a question for all, and if we have the expert, because as we say, we don't do that many. Maybe I've done 50 or 60 reanastomosis. I have seen 1 stenosis that we solve with balloon. So that's why my question was not to trap you because I know that we are on the same side, but I think that my question is why we should do reanastomosis, as I feel that we deal with young patients, so I mean that we are going to displace their anti-reflex system for life. And so the anti-reflex system we do is not as performant as the normal one. So I think, in my opinion, it's worth it to do reanastomosis, but I agree with you. But I wanted to check.
And to be honest, when I learned, I was taught to do reimplantation when the ureter is injured at the level of the pelvic brim. And if it's injured lower than the pelvic brim, it's indication for implantation. And then progressively, I learned that if you have 1 centimeter of distal part vascularized correctly, you can do reanastomosis.
Yeah.
And if you...
But discussion is still open between urologists.
If you have a problem of your anastomosis, you can always do a reimplantation. It's not a field dissected, so the reimplantation, if you have seen, it's not a big complicated task, but and the area is not dissected.
How long you let the Foley catheter after reimplantation? After reanastomosis?
Foley catheter minimum 2 weeks, and JJ stent 3 months.
Nasir.
For the proximal part of the ureter, in your case, you have an implantation. Have you close or obturate that part immediately, or how you relate the proximal portion of the ureter near to the bladder?
You can ligate it with a stitch. You can coagulate it. And you can put what you use for the appendix, this endoloop.
Nasir, here. Look, I think probably complications when you do the reanastomosis are linked to the tension of the anastomosis. And as when we deal with the bowel, we release the bowel in the upper part, but we are not used to do that with the ureter. Do you think we should do that?
Absolutely.
You know,
You
go
need
up
to
and
have the 2 segments reaching each other without any tension. So the principle of putting a stitch, wherever you put a stitch, it has to be good vascularization in order to heal. So tension-free is the rule to suture and anastomosis.
One online question. For dissection of extensive nodule on top of the ureter, do you think using suction is a good instrument, or it's traumatic, better to use another one? And what instrument to dissect?
If it's not bleeding, no need to use the suction. The suction is just to clean. You can use, you need tiny instruments and blunt dissection. So the dissection with the suction device is not always helpful to remove strong and hard tissue. So according to the situation, you have seen that we were using the scissor, opening the bipolar, little cut. If there is some bleeder, you can help yourself with the suction. So every situation is different, but the rules are to use blunt dissection, no energy, stretching, progressive, and sometimes you have to cut.
This part of omentum is not detached from the main part of omentum.
Absolutely not. It has to be vascularized. So you always keep, if you want to bring, you see the situation. If you don't have flap coming down, you can use peritoneum around to separate the, for example, for the bladder and stitches on the bladder, sometimes we use a flap of the peritoneum just to separate the stitches. So if you have big omentum reaching the pelvis, the idea is just to cut a flap, whether right or left, in order not to come in the middle abdomen, and to keep one vascularization of gastroepiploic artery, whether left or right.
Yes, and imagine situation, we are late, we have formed ureterovaginal fistula, and what period of time you recommend to reoperate this patient? For example, we are late.
Yes. if the idea of delayed diagnosis is the worse. More you are delayed in your diagnosis, worse is the situation. If you can come back before day 8, it's advisable to reoperate if your diagnosis is before day 8 or 9, before the inflammation process is like getting big. Otherwise, if you diagnose after 10 days, what is advisable is after 48 days. And Professor Vattiez tells you come back whenever you diagnose. But it's difficult to dissect. If you come back after day 10, the fibrosis and the risk of injury of other structure is very high, because this inflammation, you can injure very easily other structure. So you have to be very...
I think the problem is how much it disturbs the patient. You know, because the problem, we have fistula which are quasi-dry. If you put a Foley catheter, a stent, and then the patient become quasi-dry. So you can wait, and then it's advisable to wait 7 weeks, as you say. If you, an early diagnosis is always difficult because the fistula are normally between 7 and 11 days. So you are late by definition. So you have to look, but you know, for example, the urologists always say, wait 2 months. But 2 months for a patient leaking with urine is super difficult. You know?
You can imagine this case. You saw the hole between the vagina and the bladder, how big it was. She was leaking like constantly a lot. So she was operated maybe a month after the... So they tried Foley, didn't work. She come then saying that
so
I cannot bear
you should
this.
do case by case. Yeah. Okay, let's move
Thank you.
to the bladder. Dottora Ussia from Italy. Can I still say Roma? Roma?
Somebody can help me with this? Yeah, thank you. This is the presentation. Yes. I can. Good morning, dear colleague. And I talk about the bladder endometriosis, and no disclosure, no conflict of it to disclose, nothing. The aim of my presentation is, okay, the aim of my presentation is how to make a diagnosis of bladder, how is the surgical technique to treat the bladder endometriosis, how to prevent complication and the outcome. I try to say this. The urinary tract endometriosis, we have read already by Nasir, is rare. The incidence is about 1 to 5%, and is present in around 20% of patients with endometriosis, and is more frequent in the patient with deep severe endometriosis, less frequent isolated bladder endometriosis. And the bladder represents the 85% of the all urinary tract endometriosis, followed by the ureter, 9%, and then urethra and kidney. When we can suspect that the patient has a bladder endometriosis? There are some general symptoms that are common to the other localization also of endometriosis, now dysmenorrhea, severe dysmenorrhea, and dyspareunia can be also if there are other localizations. But there are specific symptoms that are the dysuria, 42%, and the frequency, urgency, especially during menstruation or after menstruation. And urinary tract infection in 18% of cases, hematuria only in 12%. But what is also important, that 30% has no symptom, is completely asymptomatic. What we have to do when we suspect? We can make diagnosis. The best to do a diagnosis for the bladder is ultrasound. We have seen with Caterina Zacustos a very nice imaging of this, and also clinical examination. You can feel the thickened area nodule in the anterior fornix, and to feel the uterus very attached to anterior to the bladder. But it is important to make a diagnosis with the ultrasound is to do the ultrasound with the full bladder, and then you make empty. Most of the time, many gynecologists, many colleagues go to the empty your bladder and then start. No, first do the ultrasound with the full bladder. Like you see in this, you can see very well here the imaging, and what also MRI can be good to make a diagnosis. This is by ultrasound, sagittal. This is bladder, uterus, and this is the end of the nodule. And I go up. With the RMN also, you can make a diagnosis, and like in this case, the same, you can see like this in RMN. After you, what to do is a cystoscopy. I always recommend to do a cystoscopy when there is bladder endometriosis for many reasons, not only to make a diagnosis, but only to see the area of the trigonal, to see where is situated, where is located the endometriosis, how far is from the trigonal where there are the ureteral meatus. We go on. Okay. The gold standard to treat a bladder endometriosis is the surgical excision. You can have many, you can do they have to resect the lesion, doing the mucosa skinning if it's not infiltrate the muscularis, or the partial cystectomy with the full thickness resection and the suture into layers. In any case, always we do a cystoscopy, and to insert, I recommend to insert the stent in the ureter meatus in order to avoid the lesion of the ureter meatus, and always enter in the bladder in the upper part, not in the down part. The bladder anatomy we've seen already. The bladder is a smooth muscle chamber. This is the dome. This is the trigonal, where are the meat in the bladder neck, and we have the urothelial layer, lamina propria, detusor muscle, and the peritoneum. These are the anatomy, and the specific strategy is this. We do shaving if the nodule is only on the peritoneum. We do the mucosal skinning, partial wall excision, if they're only in the muscle but not full thickness. And we do partial cystectomy when all the 3 layers of the bladder are involved with the nodule. How is the strategy? Strategy is always the same in all surgery, also in the endometriosis of the bladder. First cystoscopy, then understanding. With the laparoscopy, you have to make recognition of the anatomy first and try to restore the anatomy. Then you have very skilled in the dissection technique, because to approach to do the surgery to treat the endometriosis of the bladder, you need to dissect some space and the retroperitoneal space in order to isolate the nodule on the bladder, and you have to prevent bleeding with doing the right hemostasis, hemolysis, dissection of the paravesical space in the right plane, reevaluation. When you are isolated the nodule, the bladder, you decide if you can do mucosa skinning, if you can do the shaving, or you have to do the partial cystectomy. And after the surgery, the safety test. These are the landmarks anatomic we have seen already yesterday with the anatomy. And what we have to develop for the bladder is always the paravesical space, the medial paravesical space, because paravesical space is divided in medial and lateral by the obliterate artery or ligament, umbilical ligament, that divide in two parts the paravesical space. What we have to develop develop is the medial. In the lateral paravesical space we develop for oncological cases in radical hysterectomy, because in the lateral there are the obturator nerve and obturator lymph nodes. But for what we need to isolate the bladder is the medial. And we see this is the left paravesical space, this is the uterine artery, the umbilical ligament, left paravesical space, in this way, okay? And the ureter is in this side. Okay, I go on. The limit of the section for the medial paravesical space is the floor formed by the elevator animuscle. For the lateral paravesical space, the limit of posterior dissection is the obturator nerve. This is it's very important to develop this space. I go on. Then we see, first step when we start to do surgery for bladder endometriosis is cystoscopy. In this case, you see the ureter and put a stent inside, like this. The first step, put a stent. That you can decide. Then step 2. This is a case of bladder endometriosis, and then you have to restore the anatomy. Try to understand, to have a correct anatomy of and to develop the medial paravesical space with the mobilization of the bladder. Go laterally, one side and the other side, and let the one of the landmark is the round ligament. You go inside, let the bubble go in to make the space, like in this case. Develop. This is from Professor Vattier. Okay. And you do the same in the other side. When you have the two paravesical space, you can decide if you can do partial cystectomy or have to do only the shaving or the excision or the excision only of the nodule without opening the bladder. Go on. We see. With this, you have already isolated the nodule in the anterior part. You have to separate now the nodule from the uterus, usually, and find the right plane of cleavage. This can do with a hook like this, in order to leave the nodule on the bladder. Like this case, you see. Progressively. Now the nodule is completely isolated, and you can remove the nodule. Is already open in this here, and then excise completely the nodule. This is you do a partial cystectomy in this case. You see the catheter inside. In this case, then you do the suture. Check for the ureter, check to see if there is bleeding or not, in order to have the right good place to do the first stitch in the corner, one corner and the other corner. Like this case. See the ureter there. And you can see the ureter in this case very well. In order don't damage the ureter with the first stitch. This is the mucosal skinning. This case is the nodule doesn't go completely inside the bladder, and you can excise also very gentle with the hook. You touch with the hook, not with this part, and just activate and a distance and go continuously like this. This is the mucosal skinning. In any case, even with the mucosal skinning like this, you have to suture the muscularis of the bladder in order to prevent a complication of leakage. You have the two muscularis, and you have to suture with the interrupted suture or running suture, what is your preference. This can be do one angle, corner, another corner, and interrupted suture. You can suture with the monofilament, monocryl, or with vicryl, and we prefer monocryl, monofilament. One corner, another corner, in order it's easier to do the other sutures, even if it's interrupted or is running, whatever. When it's completely open, I prefer always to do the running suture. But when it's like this, you can do also interrupted. Then continuous. Muscularis, the back, without open the bladder. Okay, I go on. Results are very good. The rate of complication very low. If you follow the rule, the right rule, to be at the end of the surgery, to check for hemostasis, to check for the ureter, to check everything. This is another case with the already removed the complete the nodule. It's open. This case. And then you see the two ureter isolated already. Look inside. This case was without put the catheter to the ureter, the stent inside. From the, since it's already opened, you do under vision during the laparoscopy, and then suturing. This was a case of severe endometriosis. Okay. And we go on. and then the bladder closure. Put the catheter inside and close the bladder. You can do this, in this case, a running suture. I always prefer to do 2 stitches laterally to help anchor the bladder or both sides, and then you can do the running suture. Use bicryl or monocryl. In the past, now we are using more bicryl, monocryl. The other corner, and always the same. You can do also 2 layer or 1 layer. Depend. Personally, I prefer to do 2 layer. Once running and then go back in order to be, I feel more confident with this. But I've seen good result also with 1 layer. Well done. It's just because we use it to do. I don't think there is any study that says better this or this. Okay, go on with after you do the safety test with the methylene blue to see if there is no leakage, and the postoperative cystoscopy you can do also to see the ureter meatus remove. I show you another. This is another nodule, another surgery. Yeah, you see, isolated. Really, just a nodule of the bladder, endometriosis. All the rest, always the same. You first recognition and anatomy, and open, go to develop in the retroperitoneal space to develop the paravesical medial space, one side and the other side, as usual. Okay, just to go to the space, I'll show you. And after to develop the 2 space bilateral, you can excise the nodule. Was a central, the nodule of the dome of the bladder. Is the nodule. But even is isolated this, you have to mobilize the bladder, developing the space laterally, central, and then suture. This case, we're very far away from the ureter meatus. You can see was just on the dome, on the top of the bladder. Yeah. Suture this, and always the same. You do, in any case, the safety test, methylene blue, and the cystoscopy if it's necessary. Okay. Finish the suture. This is done with the barbed suture and cut. And this is the result, the final result. No bleeding, that's have to check, everything is fine. Okay, I go to this is a nodule, transparietal nodule, is the last one. And in this case, you have to detach all the uterus, all the adhesion first. Nodulo transparietal. that the bladder and the uterus is after C-section. The patient has 3 C-sections previous. Always the same. In any case, the step of the surgery are the same. This you go lateral approach to the bladder as usual. Always the same step. Open the space. This is the round ligament that was infiltrated of deep endometriosis. Here, you cut, in this case, and go to the paravesical medial space. Then you go up and detach the uterus from in the right plane from the wall. And the first is always lateral. Then go on to the touch. And then you have a landmark important is the umbilical artery. You can see this. You can pull the umbilical artery to know, you know that the umbilical artery, the obliterate, divide the space, the paravesical space, medial and lateral, and then you go to the radius because the bladder was attached there, was transparietal nodule, and open the paravesical space, and then go to the radius. The landmark is the umbilical ligament. Okay. Up. And the nodule was there. Big nodule. And also the umbilical artery here is infiltrated by the endometriosis. Okay. This is the Cooper with the corona mortis. The radius is open completely. And this is the pubic periosteum and Cooper ligament. That's the nodule. In summary, after surgery, we saw the surgery is always the same step. We said already, have seen. After surgery, you always leave a large urinary catheter and check that the catheter works. And we remove the catheter at minimum 10 days. Usually I do 2 weeks, 14 days. And before to remove, I do the X-ray, to check that everything is good. And the antibiotic we give for 7 days. The patient we send home after 2-3 days with the catheter. And the complication, vesicovagina fistula is not a complication of the bladder. Usually only if you do also hysterectomy. On the urinoma there is a leakage from the bladder you can have, and the symptom of peritoneal irritation, and you find it in the ultrasound fluid in the pelvis, and in this case you have to laparoscopically to do it again and to see if there is a leakage to suture again. And the fistula I don't go to talk. After surgery, I said already what to do. Cystography is before to remove the catheter. And after this surgery, there are many publications that the result, the outcome after laparoscopic surgery is very good. These are results published from Professor Battier, the group, is 93% of the patient no urinary symptom at 2 years after surgery. And all the other publication I've seen in the literature report at least the same result. In conclusion, laparoscopic surgery is the gold standard and the primary approach for the bladder endometriosis. There are low risk of complication, long-term relief symptom, and low rate of recurrence. Thank you.
Thank you, Anastasia. It's true that the bladder is the easiest part of the urinary problem. You didn't talk about the risk of small bladder syndrome.
Of?
Small bladder syndrome post-op.
I didn't talk. Yes, could be the risk of small bladder syndrome. I never had in our patient we did in the last 30 years, no one. I've seen one patient that was operated in another place in Verona, and with the problem of a smaller bladder syndrome. Maybe they removed too much.
Yeah, you have to be economical.
It has to be economical, only on the nodule. Don't remove more that is necessary. This is important. The message is this. But we never had once in our cases. I saw one patient that was a large.
Any question? Yeah.
If you have a patient who is coming for general symptoms of endometriosis like dysmenorrhea and dyspareunia, and she has no urinary symptoms at all, but with ultrasound you find bladder endometriosis,
Yeah.
do you go to treat it or not?
If the patient has no symptom,
No urinary symptoms, but she has general endometriosis symptoms like dysmenorrhea, dyspareunia, but no urinary symptoms.
I do surgery, yeah? I understand well, I don't know.
No, the question is, you have a patient that has a deep endo, including a nodule visible at the MRI as ultrasound in the bladder, but no urinary symptom.
Yeah.
When you operate, do you touch the nodule, yes or no?
But we had already, I did. We removed also the bladder nodule. Yes, we did. But usually we see before, we inform the patient. And because even if she has no symptom, maybe 30% has no symptom, but this nodule can growing, maybe can have symptom later. For this reason, I don't know. What you think? What you think?
For me, I think that depends on the localization.
Yeah.
And
but
if the
we did once,
localization
we
is
removed it.
like the one you have seen on the dome, I will not touch. Now, if this is close to the ureter meatus, maybe I will be.
But the dome, the patient had the symptom, recurrent symptom.
The question is a bit tricky because most of the time it's like the shoulder pain. You know, most of the time, if we always start by a 360 look of the cavity and we find a nodule on the diaphragm. And you say, but the patient has no pain, but we don't ask her.
I don't touch. She's no pain,
And
diaphragm, I
as
don't
she
touch.
did not rely this to endometriosis, maybe she doesn't talk.
What do you think, Philippe?
So that's why we have to do exhaustive, I think you have to get an exhaustive questionnaire for those patients. Because even we say 50% of those patients has no urinary symptom, I'm not sure. If we do a proper anamnesis, maybe they will describe. And in my occasion, we had the same problem for the bowel nodule, same problem, much more for the bowel nodule, by the way. Where we find a nodule in the rectum, but we say, but the patient has no bowel problem. What do we do? Yeah.
No, okay, the philosophy in endometriosis is don't touch if there is no symptom, especially for the bowel. The only indication for surgery is the symptom, okay, if the patient has pain. For urinary, I'd say that many patients, even if it's no real symptom, they have later or have not symptom really related there, but they have some problem. We discuss with the patient and decide, but depend on localization, maybe can have a symptom later, depend. But most of the time, the indication for surgery is a symptom, and to do surgery is always to do just the necessary, not more, not go more for this. This is the message.
Anastasia?
Yeah.
Do you recommend performing urodynamic study prior to surgery in this case?
In this, I didn't catch. Cosa?
Urodynamic
mean-
study prior to surgery in this
For the
case?
suture.
Urodynamic.
Can we precise the question? Do you mean when you find a nodule in the bladder to
Yeah.
do a systematic urodynamic?
Yeah.
No, we don't.
No.
We don't. We have done study urodynamics on
no.
the posterior compartment. So I mean that when we had found nodule on the posterior compartment due to the proximity of the innervation,
Okay.
we were looking for some urodynamics problem, but it has not been very conclusive. So I'm not sure that it will bring something. But why not?
Okay.
No, the question is when you have a nodule. For me, the real question is: I have a nodule. Should I stent or not stent the ureter? That is my question. And I must say that I was largely stenting in the past. Now I decide during the case, because it's so easy to stent during the case because you do it under vision.
Also, stent can be harmful for the patient. You have to do when it's necessary. Always this. Do
But it's mainly for the
necessary.
suturing.
Not too much.
For the suturing is, I always listen that the bladder is a good mother, we say, because it's easy, or forbidden mother, whatever. But it's not true for endo. And it's not true for this type of cystectomy. It's true for if you make an injury to the bladder, make a small hole to put a stitch is fine. But when you make this kind of cystectomy, you have to pay attention the way you suture. For example, do not let any mucosa out. The problem, the bladder is like a bowel, is a mucosa covering a muscle. When you cut a muscle, it retracts. When it retracts, the mucosa do not retract, so automatically you have the kind of flowering of the mucosa out. Okay, and especially the bowel more than the bladder, but the bladder also. So you have to pay attention, bowel, bladder, that when you suture, the mucosa is inside. No mucosa through your suture line, because that doesn't heal, and then you have a fistula. So you have to that you have to pay attention. Thank you, Anastasia.
Thank you.
Alors now, bravo. Wait, now let's speak about outcome. Can we tell to that we are a little bit late?
That's fine. That's fine.
Ramon from Spain. Barcelona. Let's be from Barcelona, Italy.
Okay. Thank you, Professor Patel, for your introduction, and thank you very much for your invitation. We're going to talk about the outcomes about urinary tract endometriosis. We're going to repeat some data. This is the timeline of my presentation, just to reinforce the concept. So we have been talking about the incidence. It's quite low. Bladder is much more frequent than ureter. Normally, the left ureter is the most affected, and normally the endometriosis affects distal segment of the ureter. Yes, as soon as you find ureter involvement, normally it's associated with endometrioma or deep endometriosis. That means that an isolated form of ureter involvement is really rare. As it has been told before by Nasir, it has extrinsic and intrinsic types. More frequent is the extrinsic one. And this will modify our technique when we are operating them. What about clinical symptoms? And as it has been said, most of them can be asymptomatic, so you have to be aware of them. And that means that afterwards I will explain when we have the diagnosis, most with the ultrasound, Dr. Exacoster said, it's very important to be aware of the kidneys as soon as we do ultrasound. These are data from Professor Vatier's study, and we see that, yes, this kind of patients that has urinary tract endometriosis had symptoms about dysuria and maturia, but more in the bladder endometriosis and not in the ureteral endometriosis. Again, as it has been said, ultrasound is very useful and it should be the first tool. Second one will be the CT, mostly in the complications to see not only the idonephrosis, but where is the stop or the injury. The retrograde or antegrade urography can be useful as well when we have doubts to see when, mostly in the complications, when you have a leakage of the ureter or fistula. And of course, RMI provides a multi-compartment assessment and can be very useful and necessary sometimes when we have these cases. In bladder endometriosis, obviously, cystoscopy very, very important to look at the trigon, to look at the distance in between the distance of the entrance of the ureter and the lesion that we found in the bladder mucosa. And finally, the scintigraphy is very necessary before we perform any surgery with a moderate grave hydronephrosis to see the kidney renal function. So these are different imaging tests and has pros and cons to perform them. And here we have an schematic. So we first start with a transvaginal ultrasonography, and with detection the distal ureteral stenosis, we can perform different images tests, like that is normally recommended the magnetic resonance imaging, like Professor Vatier said. And as soon as we see a sign of renal atrophy, it is recommended to perform a scintigraphy to see the renal function. We present now this clinical case. It's a 42-year-old woman with left parametrial involvement and homolateral ureteroidonephrosis. We could perform a differential diagnosis with cervical cancer because it has a novel cervix, negative HPV and normal cervicovaginal cytology, and we can see these images of the RMI. In that case, we perform a left protective nephrostomy before the surgery that we will see in the video that it was helpful in this situation. You will see. So, once again, to repeat all the classical concepts that we have shown in different videos, well, we start by the left side. We follow the so-called white line at the physiologic adherence between the sigmoid and the left psoas. So we are in the left side trying to identify the IP ligament, left IP ligament and left ureter. In that case, we introduce ICG through the nephrostomy, and the image is not very nice because it was an old system from Olympus that, but it was useful also. We detach the left ovary from the left fossa to avoid the injury, and as soon as we came to here, we have some problems with the uterine vessels, and we decided to change the strategy, and so we came to develop the Jabuki space, the entrance of the ureter in the bladder, and to check again thanks to the endorsing in green that afterwards Dr. Ferreira is going to present. Yeah, normally this base loop can help us. We put some yeah, it's very nice to pull ureter without damaging the ureter. And we can see, like, endorsing in green, these difficult cases can show us the way and make our work easier. This is the final result, how the ureter enters the bladder and how it's fully dissected without any injury. Okay, let's talk about outcomes. These are data from Professor Vattier, so it's a retrospective study, more than 50 cases. As he said, ureterolysis performed in all cases, only one ureteral injury. Another study with 43 urinary tract endometriosis cases. Most of the cases were bladder endometriosis. Again, most of the cases, almost 95 of the ureteral endometriosis were solved by ureterolysis. Very good rate of complications, only one reintervention by ureteral stenosis. And why is it important to operate? Because yes, when we have symptoms, the symptoms improve dramatically and they keep better till 3 years afterwards. What about fertility? So it seems that this kind of surgery does not improve fertility rates. In this study, it was an adjuvant treatment after surgery that was an independent factor associated with lower fertility rates. We can see here in this systematic review, more than 22 studies, more than 1,300 patients. Again, more left-sided ureteral involvement. Ureterolysis was performed in most of the cases, around 70% of the cases. It was curious because the study recorded 1/3 of the cases had a GG stent before surgery, and we can see that just the prevalence of ureteral injury during surgery was 3.1. And ureteral stenosis after surgery was not very low in these studies. The problem is that this situation is really infrequent, so you can see all the series that has, unfortunately, very low cases. It's difficult to standardize what to do. This would be a good planning to show. So the first, as soon as we have a high suspicion of hydronephrosis, we can check if it is a really high obstruction. We have to check before the renal function, and if it is below 10–15% and it has a symptomatic, sometimes can be recommended to perform the nephrectomy in cases of symptoms, pain, or urolithiasis. If the renal function is right, we can then move to do uterolysis depending on the size of the lesion and the location, as it was. Is this below the pelvic ring, and the size of the ureter can be performed. As it is said, uterolysis is the most used surgical technique, but also the ureteroneocystostomy can be done in some cases. What about GG stent? So it has pros and cons, as it has been said before. Can guide the ureterolysis, has the rapid identification of the ureter, prevention of ureteral lesions, but the cons are the increasing rigidity of the ureter. It difficulties the dissection and can add cost and time. Probably the green, endorsing in green, it's a more clever alternative to the GG stent before surgery. I recommend you to review these guidelines from the urology in case of complications, very complete, very nicely shown. They recommend to visualize and identify ureters in complex surgeries before completing surgery. It is seen that there is no strong evidence of using preoperative prophylactic stents. As soon as we recognize our ureteral injuries, recommended to solve it during the surgery. In case of delayed diagnosis, we can consider to perform a nephrostomy or even a GJ stent. And finally, to manage ureteral structures can be by ureteral reconstruction or even by dilatation, ureteral dilatation. This is another schema that is more or less similar to the one that I presented before. It is really very important to check if it's an early or delayed diagnosis. If the diagnosis is after 3 days, normally you have to delay the surgical solution because of the inflammation. And what about bladder endometriosis? Normally the transureteral resection is a technique that performed urologists is contraindicated because you normally leave lesions underwards. It's good to make a diagnosis but not to solve the problem. The segmental bladder resection is the most recommended technique. Again, with data from Professor Vatier, so it's 2/3 of the bladder endometriosis were solved by partial superficial excision and 1/3 by partial cystectomy, but we see that the chronic pelvic pain and the bladder function was better results with a partial cystectomy. So as more aggressive with the complete of the resection are better the results. This retrospective study from 31 French hospitals included 232 urinary tract endometriosis. Again, most of the ureter involvement were solved by ureterolysis, and you see that almost all the bladder lesions were solved by partial cystectomy. The complications, the rate of complications was not low, was 26, but most of them were grade 1-2 of the Clavien-Dindo classification. And what about the robot? So it seems that the robot, if we compare with the ureteral reimplantation, has no benefits in terms of durations of recurrence, but in this systematic review, we can see that the hospital says it seems that it's lower. I would like to show you now, so I can consider I am a laparoscopist, mostly surgeon, but since 2 years ago, we have started with a robotic platform. We had an XI, and since March, we have the ISP platform from the Da Vinci. I'm going to show you this clinical case. This was clear cell ovarian carcinoma on the right side. A colleague performed a previous annexectomy by laparoscopy and had to dissect the ureter trying to avoid to damage it. And we had to perform all the complete surgical staging, and we realized in that surgery that the ureter was really, really involved in the disease. So after doing, I will try to explain you the different characteristics of this platform. The entrance is through the umbilicus, and the incision is less than 3 centimeters. You can see that the arms are bending, and you can place the arms wherever you want. We have done used different techniques, but we are used now to use 2 bipolars as a left hand and 1 scissors in the right hand. The good thing of this system is that you change the tip of the scissors, so you can have cold cut, but they are not really very strong. So in that case, it was really sticky. And again, we placed a base loop to move the ureter and to have a better mobilization. So as soon as we have the robot since so little time, we are just learning ourselves how to use it. One of the problems of this system is that as soon as you cannot do strength with your arms because the arms bends, and also the jaws are not really very strong. So as soon as you have very fibrotic tissue, it's really difficult to open the jaws to dissect. Here we identify the right obturator nerve, and I would say, like, one of the classical characteristics of robotic platforms, that the view is so really so, I would say, amazing, and we can see we can be very near from the disease and do a very delicate dissection. On the other hand, when we are talking about energy, this platform, robotic platform, has a very nice energy system, so you can use very delicate application of even monopolar energy very near the event in this case without injury. You can see here that we started the cold cut, but as it was so sticky, it was not strong enough. And then after completing the hysterectomy, we could free all the right ureter. After this part of the surgery, we complete the surgical staging of this ovarian carcinoma. To conclude, I would say that it is a ureteral tract endometriosis that it has been considered rare diagnosis, but it happens. It's much more frequent, the bladder involvement. Surgical treatment is associated with a better clinical outcome, so we have to consider always to operate, as it has been said. Ureterolysis and bladder shaving are the most frequent techniques, and finally, the minimally invasive approach is the elections, as offers good results with low complication rate. Thank you very much.
Thank you, Ramon. Any comment or question before we move? Good. Efficient.
No, I want just to say something about the case of the small nodule, isolated nodule, that you said, why remove? I forget to say that this patient was very symptomatic during the small nodule like this, was very symptomatic. She had every month hemorrhagic cystitis and pain. For this reason,
but of course.
even with small nodule, maybe bigger, nothing, and small. And simple.
Okay. Thank you, Ramon. Now we are with Helder. Hi, Helder. How are you?
Hi, Prof. Can you listen me?
Yeah, we listen to you. So Helder is in Porto, Portugal, and he will perform some surgery for us tomorrow. And I think tomorrow will be bladder endo, no?
Yes. In fact, I was following the course this morning, and I think it will be interesting to present the case of tomorrow, because it's quite big nodule, more than 4 centimeters, very close to the trigon. So I will put in practice, or we will try to put in practice most of the knowledge that we're presenting this morning by Anastasia. and also by Ramon. So, hello everyone. Thank you, Professor Vatier, for the kind invitation. It's always a great pleasure and honor to join. This time, not in physical presence, but IRCAD with you has been my school. And next course I will be there for sure. So my mission is to speak about an interesting topic. I know that the launch is just around the corner, so I will try to respect the time. But it was in 2011 that in our experimental lab in Porto, we had the opportunity to try for the first time. It was a study sponsored by Karl Storz in that time, this image-guided technology with indocyanine green, with ICG, and we published our first study in 2015. In fact, these were the first images, the first video that we recorded showing the lymphatic mapping in a live swim model using the indocyanine green technology. We became very happy in that time, and after so many years, you will see, or you already are aware, that this ICG pathway has become very important in our surgical practice. But ICG indocyanine green is not new. It was developed in the Second World War as a dye for pictures, for photography by Kodak. It was tested at Mayo Clinic in 1957 for testing the liver function, for checking the small vessels in the retina, the arteries and the veins. It was approved in 1959, and why it has done a very positive development in the medical field, because it is not metabolized in human body, rapidly removed by the liver. And how does it work? It delivers a fluorescence, of course, using a specific scope and specific camera, and this fluorescence can be detected intraoperatively, and it can be very helpful. I will present to you several indications. When injected intravenously, it stays confined to the vascular compartment, and when illuminated by an infrared light source, it emits the fluorescence. It has been used in different specialties, hepatobiliary surgery, look for mapping the gallbladder and all the biliary branches, like you see. Also in plastic surgery, in reconstructive surgery, to check the vascularization of the flaps in tumors. It can be injected intravenously, as I said. It can also be injected submucosally, and it stays in the lymphatics and intra-organ, for example, for mapping the bladder. That can be helpful in endometriosis. I will show you some cases, and of course other organs like the gallbladder. We published our first review in 2019, different applications in gynecology. This has been quite cited study. In that time, we divided oncological and benign applications. In oncology, I will just show you how we made the development from this methylene blue injection in the cervix to map the sentinel lymph node. But then we moved, after the literature and all the studies were consistent about the benefits of indocyanine green versus methylene blue, we started to use the indocyanine green, and look, the improvement that have has happened in the quality of the image since the first cameras that we use in our lab in 2011, published in 2015, with the quality we have today. We have this 4K quality picture, also with the white light that allows us to perform the dissection even with the fluorescent mode activated. Anyway, this is in oncology. But before going on endometriosis, I wanted to share with you this. For vulvar cancer, there is also this system with the scope, with the light source, and with the specific camera to identify the sentinel lymph node, and you can check this International Society of Fluorescence guided surgery information regarding the dose, regarding how we use the indocyanine green in those oncological scenarios. But my focus is endometriosis. This is a course on this very common disease. ICG enhances the visualization of critical structures, the ureters, rectovaginal plane, perfusion of different organs, but specifically the bowel and the bladder when we have bladder and bowel infiltrating endometriosis. And when there is complex anatomy of deep infiltrating endometriosis, I should tell you, last week it happened in London, the EROS Congress, Urology Congress, and they started to show live surgeries with the ureter identification using artificial intelligence, but they tried to use the same artificial intelligence for distorted frozen pelvic anatomical scenarios, and they couldn't manage because the anatomy distorted doesn't play still very well with artificial intelligence. But ICG, yes, it's relevant in distorted anatomy scenarios like in endometriosis. So it's still very interesting and promising tool. For endometriosis, we can check the bowel perfusion, identification of anatomical structures. Also, there are several small studies for the checking the irrigation of vascularization of the vaginal cuff. I also want to share with you that the studies that have been performed to identify the implants or the nodules or the peritoneal spots of endometriosis have not been very supported of this technology, but still there are several studies going on. For example, this fluorescence could facilitate the distinction between healthy vascularized tissue and endometriotic fibrotic nodules, like in this example is very clear to see. There is a rectovaginal nodule, and if you inject intravenously the ICG in the bowel, and that is the fibrotic endometriotic nodule, you can find your cleavage plane, you can perform your shaving. In this way, probably it can be helpful in this dissection. Well, the ureters, I always say this, but unfortunately this is still a reality. We gynecologists are the biggest predators of the ureters. So if we have a tool, if we have some way that we get information about the ureteric anatomy, of course, can be helpful. For mapping the bladder, you see, we can delimitate the bladder. We will do this strategy tomorrow to go in the paravesical spaces, to go in the prevesical space or radius space. This is something that can be interesting also to check the shaving of the bladder if we are deep or not. Look, in this example, this is not an endometriosis, it's a birth procedure, but anyway, filling the organ, filling the bladder with ICG diluted solution, we can identify clearly, and in this monochromatic mode, the bladder limits finally the bladder anatomy. For ureteric identification, is very clear. We can have intraoperative real-time information about the ureteric pathway, about the limits of the ureter. And we know that in endometriosis surgery, many times we go for ureterolysis to identify the ureters bilaterally to avoid injuries of the ureter. So if we have this real-time information, probably, and there are already some studies attesting on that, we don't need to do systematically the ureterolysis when we have, for example, rectovaginal nodules or posterior compartment nodules infiltrating the uterosacral or the parametrium by endometriosis. How does it work? We go by cystoscopy. We use a 6 or 7 French catheter. We don't need to go very deep inside. Before we went very high, but now 2 centimeters it's enough. We inject 2 milliliters, between 2 and 4 milliliters on both ureters, and after a few seconds we have this beautiful picture of the ureters. Look on this example, quite severe case of endometriosis. We injected in both ureters. Look here, if we didn't have this real-time information of the ureter, probably can be simple to cause a complication, thermal complication of the ureter on that right side. So it can be used in deep endometriosis, previous multiple surgeries, adhesions, obese patients also can be interesting, and in some situations that the ureterolysis is quite tricky because endometriosis surrounds the ureter, can be helpful to have these fluorescence activated during our dissection. Again, another case, but just to show you that this is a different mode that the new cameras offer to us. Look, the beautiful ureter, but if you activate the fluorescence, probably it can be interesting to have this information during our surgery. Another example, for example, here, this is a left ovarian ovariolysis. Look, there is bleedy or small bleeders here. You don't see the ureter here. The endometriosis infiltrating the peritoneum, also these small bleeders. But if we activate and we are using bipolar energy just in this area, and because we know that the ureter passes there, we apply short bursts, very superficial, to avoid any thermal injury of the ureter. And look, this again, the table that you should keep in mind, all the information concerning the way of using the ICG in the ureter. Look at, for example, this study by our friend Eva Milznarovic that says that the ICG reduced ureteral complication rate from 22.7% up to 1.7%. This was published in Journal of Clinical Medicine. Interesting outcomes. But I want to focus on the bowel because bowel complications can be very tricky. In these young ladies, we are treating a benign disease, and if we have for example, bowel anastomosis leakage, if we have a fistula, this can be a really difficult situations for these young ladies, can be associated with more high morbidity and also sometimes mortality. Look at the numbers, and if we have a way that gives us information or gives us the possibility to reduce the risk of this bowel anastomotic leakage complication. Of course, we can increase the safety of this procedure, and in fact, after a segmental resection or even after a discoid resection, if we check the bowel vascularization nearby the stapling line or nearby the transection area, it gives us information that we should transect over there to perform the anastomosis with well vascularized bowel and then reduce the risk of leakage. In endometriosis also, we should be very conservative. Look at this example, and the ICG can be helpful telling us about the transection line. But again, I want to show you these fluorescence are quite homogeneous. There are no dark spots. If there are dark spots near the stapling line, it means that there are any issue concerning the vascularization, and probably it can interfere with our practice, namely to reinforce the anastomosis. Look at this example. We bring out the loop to identify the transection line. We injected ICG intravenously. We waited between 30 and 60 seconds, but exactly, or more or less exactly, after 30 seconds of injection, we start to see the fluorescence, the vascularization of the segment, and we see that transection line is over there. This is quite helpful. I remember before we used the fingers to feel the pulsation and the beating of the arteries, also looking at the color of the loop, and I think with ICG can be more interesting. I like to show you this example. These are the safety maneuvers after a resection. And look, we start always by the gas test. We inject the gas. There are no bubbles. We also call it the Michelin test. We became happy, but then we test also with the intravenous ICG test to check if there are dark areas near the stapling line. And it looks more or less homogeneous. Look, the stapling line. And then we moved to the intrarectal ICG injection, and look, you see, there is some ICG solution coming through the staplers, and after this we reinforced the anastomosis with extra stitches, using in this case a barbed suture. But just to tell you that safety should be a priority in bowel surgery, in endometriosis bowel surgery, and then ICG can be interesting in assessing the vascularization, but also in these safety tests. This is the transrectal approach of the anastomosis to see if there is any bleeding that is quite common, and also if there are any issues concerning the vascularization. The literature finally starts to support its use in colorectal surgery. Several interesting articles and studies that I recommend you in important journals like the Annals of Surgery, and this one in the Lancet concluded that there was a statistically significant reduction in anastomotic leak rates when ICG is used for left side colectomy. And look again how does it should be used to get the best results, the doses and all the dilutions, and again the 30-60 seconds after the injection to have the fluorescence. To finalize, this fallopian tubes that in endometriosis many times should be checked at the end of the procedure. Before we use methylene blue, now we are using the ICG. I know that this is not a reality in every country, but in our country, ICG is a little bit cheaper in comparison with methylene blue. So if we use the ICG to identify the ureters, if we use ICG to check the bowel perfusion, we can use also a bit at the end to make the final tests of tubal patency. The nerves here, I said, there is some teams that are making research on that with ICG, with artificial intelligence, as I said, urologists, they are working a lot on that. This was a study published in Fertility Sterility by the Japanese team. They injected ICG 24 hours before the case, and look, it was possible to map some of these hypogastric nerves, inferior hypogastric nerves. But again, I want to say that this ICG still have a potential for this nerves mapping. I don't see artificial intelligence in the next time to map the nerves in such a way in endometriosis scenarios or pelvic inflammatory scenarios that anatomy is distorted. Of course, if we start to give more and more videos to the AI platforms of these situations, probably it will come. But I think still ICG is the standard for this approach. To finalize, is becoming well established. You have seen different applications in gynecology and in endometriosis surgery. Look, for example, for ureteric identification in robotic surgery for advanced endometriosis, comparison between junior versus senior surgeons. Look at the results. Enables junior surgeons to achieve outcomes comparable to the seniors. This is something remarkable. It was published in Nature Scientific Reports, what is a quite reliable journal. And the combination of the crispy 4K image with the ICG technology is contributing to minimize the minimally invasive gynecological surgery. This was my message. Thank you very much for your attention. Inviting you to Istanbul very soon, but also to Porto next April 16, 17, 18, discussing pelvic pain with Arnaud Vatier and all the team. Thank you very much.
Thank you, Elder. Thank you, Elder, for this complete, exhaustive presentation on ICG. Any question? Me, I told you I am super convinced for the ureter. I'm less convinced for the bowel. This is my position. I don't move.
Why less?
I don't move so far. I don't move so far. No, because I think that all the studies you show and which are true, most of the time include mostly only cancer patients, and which is a population which is a part of endometriosis, and those are large specimen removal and radical colectomy most of the time that we know perturb drastically the vascularization. So I'm sure that in that case, ICG would be or is useful. For endo, I have doubt because as we discussed since yesterday, and we will discuss again tomorrow. I mean that par precaution, we don't do the the total mesenteric excision, but the transmesorectal excision. I mean the risk of devascularization is super low. And so I am afraid that if we push the interseed, people will find happy to do back to something more, less economical, and start say, oh, we have the ICG to test how much we should remove after that. I'm not convinced. Ureter are 100%. I even say that I think that it will be difficult in the very near future to do deep endo or frozen pelvis without it. But for the rest, any comment? Yeah.
Yeah, hi, it's Muni Junejo, colorectal surgeon. So have you looked at how many cases have required you to change your line of resection with ICG when you're doing segmental rectal excision with closed bowel wall resection? Because when we looked at, we're looking at a review and a meta-analysis, because there are two more RCTs that are just published. And they demonstrate that there's a 30% difference in your line of excision based on ICG. And when you randomize patients who have ICG and adjustment to patients who don't, the difference in anastomotic leak is 8% and 13%. So there's a significant difference in morbidity, complications, and death and all of that. So if you're doing a closed bowel wall resection, and here's the transferability of the technique, how many times have you had to change your excision demarcation based on ICG? Has it
Yes.
changed your...
Yeah, that is a good question. And in fact, in the first case, I can say in the first 20, 30 cases, we didn't change I think one or two cases. But after getting more familiar with, and of course, there is a learning curve for the injection and for the time of injection and for also, for example, the distance between the scope and the bowel. We haven't published that, but we really got the impression, and we have the outcomes that I hope that we got more precise where we do the transaction line than we were before, and in that way more conservative. Of course, no randomized study, not even a comparative study. This is just our impression. Taking into account, we have more than 150 cases performed since all these years.
Can I comment on that? What you said that in the study you mentioned that they changed where they do their cut because thanks to the ICG. This is what you said. Okay. And the population was what? Yeah. But that's the point. Because what is nice in the video you show, like the video that you go in the dark and you look at in black and white mode the vascularization, and then when you see clearly, and then if you stop your video before applying the ICG and you ask me where I will put my cut, I will put it by eyes exactly where the ICG stopped. So I mean.
And you'd be right 70% of the time, but wrong 30%.
But I'm not sure.
Yeah, but if you're doing a radical excision and taking out the IMA...
No, but that is different. No, but that's the point. That is what I say, yeah. I say that if you take out the IMA, it's more difficult.
Yeah. But it does make the point underlining that visual estimation is not correct all the time.
Yeah, if you make an inter-expert evaluation, if you will, yeah. Okay. But the future will let us know.
Yeah, and it's true that we need more studies concerning.
But where I am really in agreement with you is there is a learning curve. So the people don't believe that you just have to check and you will immediately, even for the ureter, you have a small learning curve, maybe faster for the ureter, but for the perfusion. And as I think this is what you said, but even with the ureter, it depends how far you are from the ureter with the light. And sometimes you can miss it just because your scope is not the place which is even more for vascularization. And did you speak about, because I believe more in the vascularization of the ureter. You have to decide if you have to reset or not.
Yes. I mentioned briefly that monochromatic mode and the intensity mapping mode can be quite interesting to check the irrigation of the ureter. I will share with you this video. These modes that the industry is working on are very helpful. You see, the ureter is very homogeneous.
Yeah.
If there is a burn, if there is a thermal injury, it becomes dark, it becomes black.
That I think it will be important.
Fortunately or unfortunately, I didn't, I still haven't a case to show here, but I've seen already in some congresses some colleagues showing that, but it's very clear to understand.
Tomorrow you can burn the ureter and we look.
Okay.
Okay, Elder, thank you very much. So we will be with you tomorrow, and thank you for this informative lecture, and thank you to be on time because we are almost exactly on time for once.
Thank you very much.
Thank you. See you tomorrow. Bye.
Thank you. Thank you.
Okay, let's have lunch. So, and at 2 we go. We don't come here anymore. We go directly to the lab. And the lab today is, as I said, we are going to repeat about the same thing, but better and faster. Okay.